All right. Hi, everyone. Thank you for being with us today. I'm Katie Starantino, the Director of Wellness Initiatives at Friends Life Care. Before we get going, I want to remind you of a few little housekeeping items. The first is that you're going to see a Q&A box at the bottom of your screen. Looks like two little bubbles, and it says Q&A, and that's how you will ask us questions today. We're going to take the questions at the end and get to as many as we can at that time, but feel free to put them in the box as we go. And then you're going to see three little dots at the bottom right that say more. And if you click those, you'll see captions. So if you want to put on closed captioning, if that's helpful for you, please feel free to do that. Okay, I would love to introduce our speaker. I am very excited and thrilled she's here with us. I got to meet with her before the presentation, and there is nothing she does not do. So I'm very thankful that she found time in her busy schedule to come and be with us today. So I'll introduce her and then we will start today's presentation. We have Dr. Cabral with us. Dr. Cabral is a double board certified neurologist and psychiatrist at the Banner Sun Health Research Institute in Arizona. So she's hopefully having much nicer weather than we are here in Philadelphia today. She earned her medical degree from the University of Arizona College of Medicine and completed a combined neurology and psychiatry residency and neurodegenerative disease research fellowship at Brown University. Her interest in dementia began while working as a program assistant for a local hospice dementia program. Dr. Cabral cares for patients and families at the Banner Cleo Roberts Memory Center. She leads several Alzheimer's clinical treatment trials and has grant funding for initiatives to increase diversity in Alzheimer's clinical care and research, and to improve the safe and successful collection of cerebral spinal fluid neurodegenerative disease biomarkers. So thank you so much for being here with us today. I'm thrilled I got through that last sentence because the cerebral spinal fluid was a tough one for me. And I will hand it over to you to talk with us about the hope on the horizon.
Well, thank you, Katie. Thank you for having me. It's an honor. And yes, it is. It's pretty hot and actually humid here. It rained last night in Phoenix, so that is new and exciting, or not often. So you heard a little bit about me, so I'll jump right in. But just to start with, I'm really excited to be in this field of medicine of Alzheimer's disease and related dementias. As I'm sure you all know, there's so many exciting things happening, especially just in the last few years, so many advances. It's really incredible. And we're really in a paradigm shift where there is hope on the horizon. So there are my disclosures. Katie mentioned a little about my background, and so I just like to elaborate on that a bit because it's a little bit different than a lot of my colleagues in terms of why I'm so interested and passionate about this field of dementia and Alzheimer's and other forms of dementia. So when I was a pre-med, when I was amidst applying to medical school, I got this job for a hospice dementia program here in Arizona, and this was in 2005. And that was a new effort in the world of hospice to have dementia-specific training for staff members to care better for people who are dying of dementia, and to help support not only them, but their loved ones, their caregivers. And as many of you may know who have had this experience in your life, in your family, there really are unique needs of people who have dementia at the end of life and at every stage of the disease that a typical hospice care model didn't at that time address, because it was more of a model of helping people who are dying of, say, cancer, who could verbalize their needs. Whereas if you have someone who's dying of Alzheimer's disease, they often can't speak, they can't move. But what I saw was that the care that we were offering was unique, and we focused on different kind of sensory approaches to help people. So things like music, things like massage, pet therapy. And so I would get to witness, someone who they didn't seem like they were there for the longest time. They weren't engaging with the world. And then they start tapping their toe when you're playing the music, that they listened to when they were in their teens and 20s. And that tapping of the toe is actually a major like response for someone in that situation. And to see how that affected the family members too, to have that person kind of come to life was so powerful to me. And then the other side to this of why I became interested in dementia, why I was so drawn to the individuals dealing with it and the family members, was because I saw this as kind of one of the major challenges of dementia is that it's a long series of losses and grieving for the person who has the disease and the family members, and everyone's dealing with different losses and grieving in their own way, and even maybe not realizing that they're grieving. And so I call myself a skilled griever because my mom died of ovarian cancer when I was 17, and she was a single parent. So I experienced this whole many years of dealing with that and grieving. And so I was able to connect in some way with the experience of dementia and the sense of loss or changing of sense of self and roles and relationships, and how, thinking about how I may be able to help people through this experience in some way. And so I ended up going to med school, as you heard, in Arizona. And then I chose to do both the neurology and the psychiatry combined residency because I saw what I saw in the dementia world. I felt like the neurologists, they all cared a lot, the psychiatrists, but it seemed like each side was missing something, a piece of the puzzle when it came to dementia. And so I do really think that benefits my clinical approach and bedside manner in the situation. And so I've been at Banner for the last almost 5 years in this field. So this is a true or false question for you all. You can raise your virtual hands or think about your response. So Alzheimer's disease can be accurately diagnosed only after death with brain autopsy. So think about that from what you know and what you've heard. Is that true or false? You need a brain autopsy to really know if someone has Alzheimer's disease. So the answer now is false. So we can, in fact, diagnose Alzheimer's disease accurately during life with a number of different Alzheimer's biomarkers, including cerebrospinal fluid or CSF, neuroimaging, and through blood biomarkers. Now, for those of you who said true, you're right too, because until about 10 years ago, that was true. And so everybody's right here, but there's been quite an array of changes in progress. And so I'm going to talk more about that today. But I would mention that even a lot of healthcare professionals still would have said true to this. So they think it's only at brain autopsy. So there's we all need to really elevate our understanding given the advances that have been made in emerging treatments on the horizon, which I'll talk about today. So what is a biomarker, just so we're kind of all on the same page with this terminology? So this is anything that can be objectively measured and evaluated as an indicator of health or disease in the body, and can also be used to track responses to medications and progress of disease. And so the pictures here are what we use in our field of dementia. So we have lots of different neuroimaging techniques. We can access cerebrospinal fluid through a lumbar puncture or spinal tap, and that's really the best window, one of the best windows into what's going on in the brain during life. And then now we have blood biomarkers, and then you see the brain, the pathologic, the tissue there, which we still use, of course. So I just wanted to give a little historical view of the evolution of Alzheimer's disease diagnostic criteria and why, how we functioned and diagnosed this along over time, and how that's changing, because I think it's very relevant and important. So in 1984 was when the first diagnostic criteria was published, and that categorized Alzheimer's disease as definite, probable, or possible. And so these pictures here, so this probably in 1984, this is what your doctor looked like. And then you have the picture there of the autopsy. So the only way you could get a definite Alzheimer's diagnosis was through brain autopsy. And then probable and possible were based on clinical symptoms that your doctor would identify. So then it took 27 years to revise these criteria. Like, that's a really long time. And then so in 2011, these revised criteria were published with a lot of changes and updates. And here's a picture of maybe what your doctor looked like in 2011. And what happened with the criteria then was that they said, okay, we're going to categorize Alzheimer's disease as preclinical, mild cognitive impairment, or dementia due to Alzheimer's disease. So they introduced this new term called preclinical, which still is not, maybe many of you still haven't heard that term, and that's understandable. But what that is referring to is that we've learned before there's any symptoms, there's a silent period of over 20 years where the Alzheimer's changes are building up in the brain. And so this is an important window of time that we could potentially intervene and change the trajectory of the disease and possibly stop there from ever being any symptoms. Then we have mild cognitive impairment, which is the prodromal, the first symptoms when a person's still functioning independently, but has progressive changes in their thinking. And then the dementia is when there's functional decline in related to those cognitive changes. So the picture here, the plus minus, so in these 2011 criteria, they indicated that the biomarkers were informative to the diagnosis, but not essential. So still really it was considered reasonable and appropriate to diagnose Alzheimer's disease just from the clinical symptoms and not from having precise biomarkers to drive that. So what really has changed this field significantly was the development and use of the amyloid PET scan. So I'm calling it the amyloid PET revolution. So amyloid refers to the beta amyloid plaques that build up in the brain. And that the development of this technology, a PET scan, it's a kind of CAT scan, and they inject, a tracer was developed to bind to the amyloid in the brain. And so once this started being used predominantly in research and following people over time, so there are these longitudinal, we call them observational studies, usually these like aging studies, where someone will come in yearly and has memory tests, mood tests, and brain scans, and then we see how things evolve over time. And so we've learned so much from incorporating the amyloid PET scan. So we learned, again, that there's this preclinical period of 20 plus years before people actually develop the symptoms of Alzheimer's disease as the amyloid's building up in the brain. We've learned what is the spatial and geographic pattern of where the amyloid starts building up in the brain and where it spreads to. And so really, it's starting out in the medial temporal lobes, which is where the short-term memory centers are in the brain, where we store new information, which makes sense since often the first symptom is short-term recall issues. Then we learned how does amyloid, what is the relationship of this amyloid buildup with tau neurofibrillary tangles, you may have heard of it, or the other main pathologic marker of Alzheimer's disease, and these start to build up later. And so then when we developed the tau PET scan, we could start to see, okay, where does tau begin to build up in the brain and how does it partner with amyloid in individuals and collectively to disrupt the brain cells and the connections between the brain cells. So the next point, co-occurring pathology. So this is a really exciting topic that we are just starting to learn about, but it's so important that everyone is aware of this, especially researchers. So we've learned that there are many people who have Alzheimer's disease also have another neurodegenerative disease building up in the brain with abnormal proteins. So for example, if we look at brains at autopsy, we've learned that 40% of people who have Alzheimer's disease also have Lewy body disease changes in the brain that are secondary. And there's some other changes too that can be seen co-occurring. And this is very relevant to potentially why our Alzheimer's clinical trials have been historically mostly negative. Okay, so maybe there's another disease happening in the brain concurrently. And if we could have a better characterization of all the diseases happening in the brains as we're getting older, we could better target treatments and find the right subgroup of people who is going to benefit more highly. Then we've similarly identified Alzheimer's mimics. And so this Alzheimer's mimics, what I'm talking about here, there's another protein that, not the amyloid or the tau, but another protein called TDP43 that we found builds up in the brains of certain people and really starts and resides, disrupts again, those short-term memory centers. And so the person has the short-term recall issues, but they look like they have Alzheimer's disease, but this other protein doesn't progress in the brain the way that Alzheimer's disease does. And so you'd have a person who they definitely have mild dementia. They have some dementia. They have what we call rapid forgetting. So, you say something and then a minute later they ask the same question and then ask the same question, but then they live, 10, 15 years and only have that same degree of cognitive impairment of memory loss. It doesn't progress like Alzheimer's. So we found out that these people, their brains at autopsies, actually they have this other issue altogether. So imagine if that was you or your family member and you learned, oh, they have this TDP-43 disease and not Alzheimer's disease. And that's very impactful for to plan the rest of your life. So, and then finally here, so I mentioned early non-cognitive symptoms. So amyloid PET scan helped us identify that there's a group of people who are building up the beta amyloid and on the trajectory, presumably to develop the symptoms of Alzheimer's disease. But their first symptom is not memory loss. It's actually mood changes or behavior changes, things like depression, anxiety, irritability, agitation, sometimes psychosis. And so these are people that this has been termed clinically early behavioral impairments. And so these are people that have no trigger, no reason to, no psychosocial stressor, say, to suddenly develop late life, new onset mood changes. Like suddenly, you're 68 years old and you start being anxious, and there's nothing really to be anxious about in life. And so this could be a reason, potentially. There's other reasons that could happen, but it's something that that especially primary care docs, maybe it would be great primary care providers to keep on the radar if you notice this is happening to one of your patients, to consider looking into that further. The amyloid PET scan also helped us develop other biomarkers like blood biomarkers of Alzheimer's disease, meaning we're very close to our blood tests being able to screen for Alzheimer's disease and indicate accurately if a person has the changes in their brain via just checking their blood. And we do this in our research studies, and we're close to having this, something that's available and paid for by Medicare. And then the amyloid PET scans are integral in our clinical trials where we're developing treatments. And so we can monitor over time if the amyloid levels are normalizing or decreasing in response to the treatment. And that hopefully means that the symptoms will also slow down significantly. And we'll talk more about that in a second. So this is just a picture of all the different things that we do, that we have for biomarkers. So we have the MRI, the structural MRI. So an MRI or a CAT scan, but MRI is much better to visualize things. And in this picture here, I don't know if you can see my mouse, but we look for shrinkage in the hippocampus or the short-term memory centers of the brain. And that's a non-specific marker of Alzheimer's disease. And then we have the amyloid PET, the tau PET, blood, cerebrospinal fluid, and then an FDG PET is another way we can look at if there's decreased energy usage in the brain. So this is just another way to look at like this graphical depiction of, the temporal progression of starting from 20 years plus is the amyloids building up in the brain, and then 15 years before symptoms, the tau starts building up, and then 10 to 5 years before is when you start seeing some changes in the metabolism and maybe shrinkage in the brain. And finally, the symptoms start. So again, this big window of time where there's no symptoms, that is really where the field is going. So when your your doctor or your healthcare provider diagnoses you or family member with Alzheimer's disease based on, say, asking you questions, doing a physical exam, and then some brain imaging like an MRI or a CAT scan, we have found that if we compare that diagnosis of Alzheimer's disease clinically to what the brain autopsy shows, that about a quarter of the time that the healthcare provider is wrong and that it's not actually Alzheimer's disease. And this is relevant also because not just to make sure that a person's getting the appropriate care, but something else we learned is that, and the amyloid PET scans show us this, in clinical trials of Alzheimer's disease, once the amyloid PET scan was introduced and we could identify if the amyloid was present, in other words, if the person actually had Alzheimer's disease, we learned that 20% of people who are in the Alzheimer's trials did not have elevated amyloid in their brain, and so they didn't have Alzheimer's disease. And so if we think about all of these negative Alzheimer's trials, there's a good portion of people in the trials who don't actually have Alzheimer's disease, yet we're getting treatments to target Alzheimer's disease. So now in our clinical trials, almost all of them require that we identify these biomarkers in the brain to know that the person actually has that before they're eligible to proceed with the treatment portion. So this is all just in the last decade that this has happened. So major advances. And so the way we're thinking about this is we're shifting from a clinical to a biologic definition of Alzheimer's disease. So rather than just looking at the person in front of me and their symptoms and what they're telling me and what their care partner is telling me, and then deciding if they have Alzheimer's disease or not, or another form of dementia, adding these biologic markers that are objective. And this is a graph of how these, we kind of talked about that already, but the timeline of when these changes are coming online. And so you see the x-axis is the cognitive status. And so that first half or more is when people are cognitively unimpaired, and then moving into MCI and then dementia. And you can see, the first curve here, the first line is the amyloids building up, and then the blue one is the tau. And you can see how the amyloid gets almost essentially to peak levels that it's going to get to as mild cognitive impairment, as the first symptoms are starting. And so really that slope, that change increases significantly long before the symptoms start. And then we see when we can, the brain structure is when we can see the changes on MRI, when there's shrinkage, and so on and so forth. So I think it's helpful to analogize the Alzheimer's disease field to the cancer field, and how in cancer, we have our cancer screenings that our primary care provider does. There's the colonoscopies, there's the mammograms, and it's done in a set frequency with the goal of identifying these diseases before there's any symptoms. So during the asymptomatic period, and if that's identified, you go into treatment immediately. And so where Alzheimer's disease field and related dementias is going to go is looking at this period of time when there's no symptoms and having screenings, and probably it's going to be a blood test that your primary care provider is going to do to see if you have elevated amyloid and tau. So just some basic statistics about Alzheimer's disease, you probably know, but so these are just recent 2023. So over 6 million Americans are living with Alzheimer's disease. There's more than 11 million Americans who provide unpaid care for Alzheimer's disease and other dementias. Like, that's a huge number. And then that equals over 18 million hours per year, unpaid, valued at $340 billion. That's incredible, right? 11.3% of adults over 65 have Alzheimer's dementia, and almost 2/3 of Americans with Alzheimer's are women, and 1 in 3 seniors dies with Alzheimer's disease or other dementia. So huge numbers, that almost so big that it's hard to process this, but really we're going to need to really confront this, and so are our payers and our officials. We already talked about some of the Alzheimer's brain changes, but here are some pictures. So this on the left is a picture of the brain. It's a slice called the coronal view. That's like coronal, like a crown. So cutting in that plane. And you see on the left is the nice, juicy, healthy brain. And on the right side is the more atrophied advanced Alzheimer's brain, where you can see shrinkage throughout. And so this is, again, advanced. This is far along in the disease when you're going to see shrinkage in all these different areas. So we have, besides the amyloid and the tau in the little box on the top right, other things that happen are synaptic dysfunction and loss. So the connections between the brain cells and neurons start to go awry, and then eventually the brain cells die, and that leads to shrinkage or neurodegeneration. And more recently, we've been thinking about neuroinflammation, which is a broad concept, but exciting to venture into many other, thinking about many other mechanisms of what causes Alzheimer's disease and what causes it to progress. This is just so that we're all on the same page with what these terms are, and that but we talked about this a little already, but mild cognitive impairment is what your healthcare provider might diagnose you with if you have progressive cognitive decline, more than expected for your age, but still functioning independently. And MCI often precedes dementia, so progresses to dementia. When it doesn't, that usually means, that would mean that it's not Alzheimer's disease, because Alzheimer's disease will always progress. But there's so many possible reasons that people develop progressive cognitive decline and aging. And that's why it's so important to get a comprehensive evaluation if you're experiencing that. So when it does progress to impact one's day-to-day function, we call that dementia. And we still often we categorize it as mild, moderate, or severe. And that has to do with the level of functional impairment that's happening for the person. So dementia can, of course, affect many other cognitive or many other domains besides memory. So it can affect language, executive function, which includes things like planning, multitasking, organizing information. Can affect visual, spatial skills, mood, behavior, personality, reasoning, judgment, gait, and motor function. And as I mentioned, because there's the co-occurring pathologies are so common, for example, like Alzheimer's disease with Lewy body disease, or even just Lewy body disease by itself, that can show up with a number of, if you're familiar with Lewy body, which is in the Parkinson's family, gait changes, motor changes, tremor. There's other things that happen with Lewy body, and that would be a whole other talk that I'd be happy to provide someday, including things like visual hallucinations, REM sleep behavior disorder. So in any case, there's many possible things besides memory loss, of course. So many people ask, what's the difference between Alzheimer's and dementia? So dementia, as we just said, is a vague term that means the progressive cognitive decline with functional impairment. And I always say to my patients, but there's 100 possible causes of dementia, and Alzheimer's disease is the most common cause. And so Alzheimer's disease indicates these specific brain changes, including the beta amyloid and the tau building up. So if you were going to have a comprehensive evaluation by me or someone similar, these are the things that I go through, and it's quite comprehensive. I'm lucky at a specialty center, I have more time to ask all these questions, but a primary care provider is really limited in time. And so they may not get through all of these things. So besides asking, the person, I always really love to have a family member or a friend there who can corroborate what's happening. And so as opposed to other areas of medicine where maybe a person, an older adult will go by themselves to their doctor, we really need to have a family member there. So then I ask about social and developmental history, medical history, of course, medications, mental health history. Sleep is something I talk a lot about. I want to learn about a person's habits and routines. How are they spending their day? Routines were decimated during COVID, but also routines are often really obliterated in retirement. And so this is something I talk a lot about. Counsel about alcohol use, substance use, family history. I'll do a complete neurologic exam and a physical exam, and then we'll do some brief bedside testing, cognitive testing. We might do something called the mini mental state exam, the Montreal Cognitive Assessment, clock drawing. And so then the next other things I'll do in that initial evaluation, I'll order some basic labs, get some structural brain imaging with an MRI or a CAT scan. We absolutely need to look at the brain. If you're coming in with cognitive concerns, it's essential to make sure that you don't have something like a tumor, stroke, brain bleed. And then after that, we're looking at those shrinkage patterns. And if there's evidence of vascular disease in the brain, and that, because that can impact thinking. And then the biomarker testing, there are things that can be ordered by your primary care, or your healthcare provider that can be covered by Medicare, which include the FDG PET scan. So that's looking at the energy usage in the brain via identifying glucose metabolism. And in Alzheimer's and in other neurodegenerative diseases, you can see a characteristic pattern of decreased energy usage. And then cerebrospinal fluid, or CSF. Usually Medicare will pay for your lumbar puncture or spinal tap to send for these Alzheimer's proteins, the amyloid and the tau, and that goes to a specialty lab. And I'm a big champion of cerebrospinal fluid as a really crucial, important part of the evaluation. And so I do spend a lot of time trying to demystify and destigmatize this procedure, because it's really not a big deal and most people can have it. And if you're at a place that has a competent provider who could do a lumbar puncture, you can get such important information from this. So this is an example of if I got the spinal fluid and I sent it to the specialty lab, this is a report that I'd get back. And so this is an actual patient's report. So I just want to show you this. So you can see the results table. They're looking at the amyloid beta, the T tau is total tau and P tau is phosphorylated tau. And then there's a ratio. And so then it's graphed here, and you can see there's the right lower is consistent with Alzheimer's disease and the left upper is not consistent. And so this person ended up having their cognitive changes were not due to Alzheimer's disease, which I suspected, but this clinched that. And so now this person can leave knowing that this is not Alzheimer's disease and feel really confident about that, because this test has a high accuracy. It's about 93% accurate in the situation. So very meaningful. Now I won't go through all of this, but again, speaking to this, moving from a clinical to a biologic definition of Alzheimer's disease, I just want you to have a sense of some of the frameworks that we're talking about in this field. So it's the ATN framework that is being discussed, and introduced. And so A stands for amyloid, T for tau, and N for neurodegeneration. And so that's breakdown or shrinkage of the brain. And so identifying or categorizing someone in terms of are these three things present or absent, and then determining, well, what's the next steps based on having whether or not they have the A, the T, and the N. And so what we know is that you must have amyloid in your brain to have Alzheimer's disease. If you don't have elevated amyloid, then it's not Alzheimer's disease. And then, so you can see in the blue on the right, those individuals are on the Alzheimer's continuum, anyone who has A positive. But the other T and N, it's variable, what we call this. So in any case, my point in just letting you, in making you aware of this, is how this is becoming more biologic, more objective. And this is what is done in cancer and oncology. So every type of cancer, there's much more nuanced identification of molecular changes, genetic mutations, receptor positivity, and then also there's the staging model in cancer of TNM, tumor, node, and metastases. So, is there a tumor present? Is it in the lymph nodes? And are there metastases? And so when that's determined, and then a person's put in a stage that then drives prognosis and treatment. And so that's where our field is heading in our own way. Now I'm going to shift to talking about, well, what do we have available now? So what do I offer to someone who's coming into my clinic who I've determined, say, has mild dementia due to Alzheimer's disease? So we've had symptomatic treatments available for 20 plus years, and these include cholinesterase inhibitors and memantine. Now, the different healthcare providers have different enthusiasm for starting these medications, and I'm a fan of them. And of course I'm biased, but I do see these as beneficial, although modestly. They slow the progression of the cognitive and functional decline. And so first line is donepezil, or a similar medication in that class. And what that does, it increases a chemical in the brain called acetylcholine that helps in different ways, depending on the person. But what we really know is that if you're going to progress at a certain rate, it's going to slightly decrease that rate of progression. So it's not going to make a person revert to how they were thinking 20 years ago. And, but it's going to slow it down. And what we see is that, so they're better off than they would be if they were not taking these medications. And we do see when people are on these medications and they're suddenly stopped, they often have a sudden decline. Now, they're well tolerated, typically. Main side effects, some people have stomach upset, GI side effects, loose stools, that's temporary, almost always. And so I think, they're worth trying, and I've seen positive things. Then memantine works differently and is often used in concert with the cholinesterase inhibitors. And memantine's indicated for a little bit more advanced disease, like moderate to severe dementia. Otherwise, I spend a lot of time counseling on, firstly, safety. So how does one have memory loss and maintain their independence while being safe? And so every visit, I talk about things like managing your medications. If you have short-term memory issues, would be very easy to forget your medications. And so it's important to adapt your systems to compensate for that. And there's a number of people that I've seen who they don't feel well. They just kind of feel crummy, and they have their memory loss. And it turns out, they're living alone and they're missing their medications, or they're taking them erratically. And once they just start taking them every day as prescribed, they have an alarm, or they have an automated pill dispenser that alerts them, or their family members start, coming over and making sure they take their medications correctly. They start feeling better, thinking better, moods better, sleeping better. Like this is absolutely important. So I talk about that. I talk about bill paying, making sure that, that there's no late notices or missed payments and things. So often asking a family member to have a little oversight if needed. And then driving safety, I talk about a lot, of course. And that's a whole other, that could be an hour-long presentation in itself. But it's so important I think, to be open and direct and transparent and just talk about this at every visit, rather than, keeping it feeling, not wanting to broach the topic because you don't want to make the person mad. And then suddenly 2 years later, I'm telling them that it's unsafe to drive and we need to revoke their license. And then they're understandably going to be very angry. So we talk about it every visit, more as a way to let's slowly scale back over time based on how you're doing, what your test scores show, what your neurologic exam shows. Driving takes an array of cognitive and physical abilities that all coalesce perfectly. And we don't realize that throughout our lives because we're so used to driving. But when you put certain features together, it can make it unsafe to drive. And then I talk about healthy brain aging, which I'll get to in the next slide. Caregiver support and resources is huge. And really, we need to, as a healthcare system, start viewing this disease as affecting, we call the dyad, the person with dementia and the family member, because it's often those people are so intrinsically connected that it affects that care partner's health and well-being, sometimes in some ways, even more so than the person with dementia. And then resource linkage, similarly, there's a lot of resources available, but it is unfortunately, very difficult to navigate the system often. So trying to connect people with what they need at that moment. So what are things we can do with our lifestyle to support healthy brain aging? The evidence is getting stronger and stronger that physical activity is one of the best things that we can do to support brain health with aging, and specifically aerobic style exercise, meaning anything that's going to get your heart pumping, get you sweaty, is going to help, because it's not because you need to lose weight or because, I'm thinking your muscles, you want to get toned muscles. No, it's because when your heart's pumping like that in aerobic exercise, the blood is getting pushed to your brain and throughout your body to the farthest reaches of your brain and nourishing your brain cells and flushing toxins. And there's so many benefits. It's also going to help your sleep, your mood. So that's definitely, I push that a lot. And it's just a matter of, depending on, you have to know, what is your background? Have you been an exerciser over your life? Do you hate exercise? And how are you going to change your routine and your behavior so that you can stick with it? So that's important. And then otherwise increasing cognitive activity. I just think of this as challenging your brain, getting out of your comfort zone. People often ask about certain puzzles or brain games, and those are all great, but I can't say specifically do this brain game, and that's definitely going to help. But just a matter of challenging your brain. And I think of it as exposing yourself to novel situations. And so that often, requires, if you can, to, get out of your house, try new things that are safe, of course. And then social activity, being social, being connected. We saw what happened during COVID due to social isolation. So people with dementia decline much quicker than they would normally and died at a higher rate. Well, for many reasons, but this is absolutely one of them. So next bullet, sleep and circadian rhythms, exclamation mark. This is another topic I'm really passionate about, is sleep. And I could spend many minutes and hours talking about this, but we know that there's a link between poor sleep and specifically untreated sleep apnea and later development of dementia. And so when I hear any indicators that there might be sleep apnea, I will refer someone for an evaluation with a sleep specialist and a polysomnography. Now, as well, the whole, what I mentioned before, often this starts in retirement, that suddenly a person's sleep-wake schedule changes drastically. And sometimes people say, well, I earned it, like I can sleep in. And also, I don't have any reason to get up, so I'm going to sleep till 10 a.m. And that's actually really bad for the brain and the body. And it throws a person off of their normal circadian rhythms, besides the sleep-wake schedule, but for the rest of the day. So our circadian rhythms encompass all of our physiologic properties and tell us, when should my body expect to have meals? And so you're going to produce, certain hormones and things and factors that are going to help you digest. And when should my blood pressure go up? And when should my blood pressure go down? And when should I expect to do these different things and be social and exercise? So if you have an optimal sleep schedule for yourself, and really the number one thing I'd say is having a good wake up time, that's really crucial. Like a fixed wake up time that's right for you. And everyone's different. And so this is a big topic that I could, I'm sure go on and on about. And sleep medications is a whole other area that really we shouldn't be on sleep medications indefinitely, but that's kind of where we've gotten to in our society, and it's normalized. Then hearing loss treatment, absolutely. This is important, and we don't fully understand why there's a link between hearing loss and later dementia, but probably it's because it's a sensory deprivation that's happening. And so if you can't hear as well, your brain's just not getting stimulated as much. And so, it's like you're losing those neural connections. And so I encourage people to get that checked out. Now I'll spend a little bit of time just talking about Alzheimer's clinical trials. So over 200 clinical trials in Alzheimer's have been negative or abandoned over the last decade. And until recently, we haven't had any drugs approved since 2003 until now, almost 2 years ago. This drug lecanemab was approved by the FDA, but later Medicare decided they weren't going to pay for it. And then recently, lecanemab, a similar drug, or Leqembi, was approved this January via accelerated approval. And we're waiting to hear if Medicare is going to reimburse for it later this year. And so both of these drugs are very different than what's available. So currently, we only have symptomatic drugs available, symptomatic treatments, but these drugs we think of as what we call disease-modifying treatments, because what they do, they're intended to remove the excessive beta amyloid in the brain, and thereby significantly slow down the progression of the cognitive and functional decline in Alzheimer's disease. So I'll talk more about those in a bit. Why have all these trials been negative, all these other ones? Well, it's not necessarily just the drug doesn't work. It has to do with how we design the trials and who's coming into the trial. So I mentioned before that we found out, 10 years ago with amyloid PET scan that 20% of people in these anti-amyloid treatment trials don't even have elevated amyloid. So now we've got to, really identify the right people. We learned that sometimes the treatments that we want to use need to be started much earlier in the disease process. So maybe even ideally before there's any symptoms. We understandably start doses really low, especially with our older adults in these studies and with the dealing with people with neurodegenerative diseases in their brain, but often too low was the dose that it wasn't effective, maybe the wrong target, and then study design and analysis. And so I won't, let's see. So I just want to make sure, because I think we're running a little low on time. So just want to introduce, so this class of drugs, these anti-amyloid monoclonal antibody treatments, which is the aducanumab and the lecanemab, those two that were approved. And there's another one, that donanemab, that just released positive findings. I have to update that. They released positive findings for their phase 3. So this is the farthest along in our clinical trial efforts that appear to be promising. And so with aducanumab, I don't have time to go through this, but it's very controversial. But ultimately, Medicare, CMS did not feel the data was strong enough to say, yes, we're going to pay $28,000 a year for an individual to get this drug based on the data that we have. And so this drug that was more recently approved, lecanemab or Leqembi, does have stronger data. They presented, so 1,700 participants around the world with Alzheimer's disease, early stages, so MCI and mild dementia. They met their primary endpoints, which are reducing the cognitive and functional decline over 18 months by 27% compared to placebo. And they also met secondary endpoints, decreased the amyloid beta in the brain, normalized it. And but there is this, with all of this class of drugs, this potentially serious side effect, which we call ARIA, which involves fluid shifts or edema in the brain and microbleeds. And that in this drug happened in the trial with 12.5% on the drug compared to few who are on placebo. And so this is just a picture. The white, like in the A frame here, the white is the edema. And then often in these areas, we'll see microbleeds, these little, like in C, the little dark punctate spots. And so that, I'm sure, sounds scary, but it's something that we found is manageable and often asymptomatic. And we catch this with MRIs, which we do frequently when we're starting this medication. So in terms of, I guess what, is every area of medicine, it's just really slow, maybe especially in dementia, to translate the research advances into clinical care. And still more than 50%, half of people who die with dementia, it's never diagnosed. And we don't have universally accepted guidelines for screening or diagnosis. So, everyone does things a little differently. And so that needs to change. And even still, a lot of healthcare providers, if you tell them you have memory loss, they don't take a picture of your brain with an MRI and CAT scan. And that's so crucial. And of course, I'm biased as a subspecialist. And so what we might see in the future, I anticipate, once we have treatments that are really effective at slowing the progression of the disease and they're paid for, you're going to say we have a 67-year-old female who's cognitively normal, no cognitive concerns. She's going to go into her primary care provider for her annual Medicare wellness visit. They're going to do blood tests to screen for the Alzheimer's changes. And then say they're abnormal, they're going to do confirmatory testing with either spinal fluid or the PET scan and say that they're positive for her. So that means she has preclinical Alzheimer's disease, and they're going to direct her to start in a disease modifying treatment and then do periodic checks. Just like if she had her mammogram and they identified something abnormal, she'd get sent to treatment immediately and monitored closely for that. I'll skip that. And then just some things to think about. So if we do have more effective Alzheimer's treatment, significantly more effective, and people are going to be now living longer with Alzheimer's dementia, will that lessen the stigma of dementia? And how are we going to care for these many more people living with dementia and their caregivers beyond just giving these medications, right? There's so many other needs in the journey of dementia. And then what services, technology, and innovative businesses may be best to support this population. Like, this is a huge area that is wide open from my perspective. So any enterprising people listening, especially with possibly we're going to have a treatment that Medicare is going to pay for starting the end of the year, like this is a huge opportunity, and hopefully people who are doing this for the right reasons are going to get these businesses going. So this is my center. We offer a lot, from clinical care, research studies, and healthy brain aging. This is a clinical trial that is going on around the country for people who are in this preclinical stage of Alzheimer's disease, meaning they have elevated amyloid, but they have no symptoms. And so this is lecanemab that's being studied in this setting. So that's the drug that was approved for mildly symptomatic Alzheimer's disease already. And so what's going to happen is, if you're 70 years old, you're cognitively unimpaired, but you're concerned because your mother had Alzheimer's, and you say, okay, I'm interested in getting treated if I'm on this trajectory. So you can go screen for this, potentially for this study. And the test they do at screening is the blood test. So the first stop is just the blood test, which is so easy to do. And if you don't have that abnormal Alzheimer's change in your blood, you're cleared. It's saying you don't have Alzheimer's disease in your brain at that moment, and you're not eligible for the study. But if you do have the changes, then you would be eligible to get the treatment. And I did look up, Pennsylvania has some recruiting sites for this study. So we're doing that at my site too in Arizona. But this is really, again, important to diagnose these things early, and even before there's any symptoms. So that's it. Thank you.
That was awesome. I feel like I just got so much information, and it comes so easily to you, but I appreciate you getting it to us in a way that makes sense. And we have some great questions. I do want to note before I go into the questions, Dr. Cabral and I talked about this before. Dr. Cabral is a doctor, but she's not your doctor, so she really can't answer specific questions about your history. So we might get to some of those, and she might say that's out of her scope. We'll see what we can do. So this question here, how close are we to an Alzheimer's blood test? That seems like the best way to catch it early, as most of us get our yearly blood test with our primary. And you kind of touched on that a little, which is interesting.
Yeah, and I might add, then people ask, well, why aren't we getting these tests? Why doesn't our primary care doctor do this? And that's a great question. So everything we do is, as clinicians, is will it change management? Okay, so right now, if you're cognitively unimpaired and say you have the Alzheimer's changes in the blood, there's not a treatment to give you. And so you're the doctor's left with like just counseling. And so at this point, they're not going to do those. But maybe for people who are expressing memory loss concerns, maybe that will be approved by Medicare to get those blood tests.
Very interesting. Can Alzheimer's develop after another kind of dementia is diagnosed?
That's an interesting question. I'm trying to think about how. So because we know Alzheimer's changes are building up in the brain for 20 plus years before any symptoms, what I see happen is someone has primary Lewy body disease, which is it's in the Parkinson's family. And so Lewy body disease basically starts with cognitive changes, and people often develop the Parkinson's kind of motor features later, a year or more later. So you're going to have, you're going to see that, but the person could also, you're going to see those symptoms evolve. But that person, like I said may also have Alzheimer's disease in their brain. And so you won't know during their life how the Alzheimer's might be impacting, their clinical symptoms. But it seems that people who have the combination, if the people at autopsy who we find they have Alzheimer's and Lewy body disease, if we look back, they progress faster than someone who just has one or the other. So someday we'll be able to work better with that and treat that, but that's where we're at this moment.
Mm-hmm. Is there any difference for sleep if the person uses hypnotics versus natural sleep and risk for dementia?
There seems to be an association with so the hypnotics, like the Ambien, for example, they're not good for the brain, and there's some kind of link possibly with later risk of dementia. So it's going to be much better to use your natural pharmacy. So your melatonin, that's going to be naturally produced. And for sleep issues, to me, it's always about, let's get to the root cause, right? And that's what it's difficult. And often it requires a person change their, we call it sleep hygiene. Like, don't, like quiet down for hours before bed, don't watch screens in bed, different things, that don't take naps during the day, so it's actually really a lot of work for the person. And often it's just like, forget it, I'll just take my sleep pill. I like it. I've been doing it for 20 years. And I personally don't. I say fine, because I've learned not to mess with that in those situations, but that's, it's a complex issue, and it's going to be better to get good sleep, ideally without hypnotics if possible. So
Thank you. This one made me smile because I always wondered this too. Would you have any simple answer to why so many new drugs names end in UMAB?
Oh yeah, so good question. So it's the MAB, stands for a monoclonal antibody.
Oh.
So we see, so MABs exist in many other areas of medicine, definitely in rheumatology, when you have rheumatoid arthritis, multiple sclerosis, cancer. So those are all monoclonal antibodies.
Very interesting. Would you comment on the APOE genetic variants as predictors of late onset Alzheimer's?
So APOE is the main genetic risk factor marker we have for Alzheimer's disease. And so it's the APOE4 version specifically increases the risk of Alzheimer's disease during life. Now, it does have a stronger connection to increasing, so individuals who have early onset Alzheimer's disease, meaning symptoms before 65, are more likely to be a carrier of that gene, and they could have one or two copies. So you get, so APOE, there's 3 possible options you could get from either parent, a 2, a 3, or a 4. The 4 is the risk for Alzheimer's. The 3 is an average risk, and the 2 is protective. So if you're a 3-4, then you have, so you're heterozygote, because you have a 15% increased chance of developing Alzheimer's during life, and probably slightly more, if you're someone who develops this early onset, you more likely will be a carrier. Now, if you have 2 copies, you have a 35% higher risk of developing Alzheimer's disease during life, but you can still develop Alzheimer's disease without the 4s. And it's, as you hear, it's certainly not a definite thing at all if you're a carrier. So I don't think we have definitive statistics on risk of late onset versus early onset, but I would just add that as a person's, the later the symptoms start, so say you're 85 or 90 when your Alzheimer's symptoms start, the less the genetic factor plays a role. So your family member was 90 when they started having their symptoms, you probably don't need to worry as much that that's a factor.
Well, that makes sense. I'm going to note we have 2 minutes left, so I'll just do 2 more questions. And I really thank you all for these great questions. This question, what level of progression slowing is clinically important? I think that, like, kind of looking at when is it? Yeah.
Yeah, no, that's the huge question as it relates to these drugs that are getting approved, like lecanemab. And we call it, what is clinically meaningful? Like, what really matters in a person's life? And are we even measuring that in these trials? So as a part psychiatrist, I think the mood and behavior changes are huge, because that's really what mostly disrupt the life and relationships and leads people to be institutionalized early, but we don't really look so closely at that. But if that's actually caused by the disease, as like I was saying, like that could be for some, and so there's a lot of controversy, a lot of various opinions about, is 27%, for example, or 30%, and what are we even comparing it to? So this is an interesting area of like debate, philosophically, ethically, scientifically, and so keep an ear out for that.
Yeah, that's a great question. And I also see that person just shared that they were an MD, they worked at the FDA. So great question. Okay. Thanks for sharing that. Our final question I'm going to ask here, are there other studies other than the tau and amyloid going on, such as the gut? And I know there's so much talk about the gut lately. So have you heard anything?
there's definitely a big interest in that growing. The gut microbiome, neuroinflammation is a whole other hot area. There's many trials going on. And I would encourage you to either go to clinicaltrials.gov or find your closest like specialty memory center that's doing trials and just call them if you're interested. So it's, there's less funding at this point. Of course, it's a newer topic, but there's increasing interest, which is exciting since obviously we don't have a cure. So we need to be more creative and have an open mind.
I can't thank you enough for being with us. I'm just so thrilled you do the work you do, and you do it with such passion and excitement. And I think we all walked away with a ton of new knowledge. So thank you for making the time for us today.
Thank you for having me. And yeah, let me, if there's any other questions, I can stay for a few minutes.
Oh, great. Well, there are. We'll do a few more. So if anyone wants to hang on, we'll do a few more questions here. Oh, yes, somebody's pointing out we do work with Keystone Clinical Works, which is one of the ones that you mentioned. So what do you think about the importance of addressing lifestyle modifications early in life for individuals who may have certain genetic predispositions?
There's much more interest now in specifically midlife lifestyle changes, and there's good data that aerobic exercise is directly related to risk of dementia 20 years later. So the level of your aerobic exercise, meaning, so say you're a woman who's 50 and you are the top exerciser, from an aerobic perspective, you have the lowest risk at 70 to have dementia. And then it's clear that, and then the opposite, the most sedentary has the highest risk of dementia 20 years later. So these are longitudinal studies, population studies in women, and that really have shown that. And so I would push for that regardless of the genetic factor. It's really hard to know per an individual, even if you're a carrier, but I think it's good. I think it's good for a lot of people to know their genetic status, because that might motivate them they're thinking about, I should get more into exercising, and maybe that'll push them to, and that's going to help everything about their health. Right. So
I completely agree. I think we've all been in that situation where you get your blood work back and you're like, oh, now I got to start doing more of this or less of this. So it would definitely be a motivation.
And I would just add, the sleep isn't maybe the next one that really, we shouldn't wait to try to improve that. And again, I always say the best thing is to have a good fixed wake up time, because that's going to reset your circadian rhythms and get everything on track. And don't worry about the going to sleep time, because if you are getting up early enough, you're going to be tired at the right time for you.
Right. And to your point, if you're doing aerobic activity, you might be more tired too. I'm going to botch this word, but I know you'll help me. It seems if we can diagnose at a very early stage, even the cholinesterase would be very effective.
Yeah. So because it's so hard to measure if the cholinesterase inhibitors are helping because they're working in the background, I personally start these when I diagnose mild cognitive impairment, when there is a change, because they are pretty safe and well tolerated. It's worth trying. And if someone is still working, say they're 60, and they're still employed, and that might just help them stay in their profession a little longer. I think it's definitely valuable for people who are in this preclinical stage, pre-symptoms. I wouldn't think that mechanistically that would be helpful, and would push the lifestyle changes first. Yeah.
Okay. And I'll do one more. What about genetic factors in diagnosis?
So that's really, we have a lot to learn. And again, if we think about cancer and how much they know about genetic mutations and molecular changes, all we really know about is ApoE, except for there's these small group of people who have these autosomal dominant mutations, which they develop symptoms in their 30s and 40s. So that's a very small group. But otherwise, what is the benefit of, when should we be testing for ApoE status? We know that when someone has cognitive impairment, it's safe and ethical to identify their ApoE status and disclose it. And people don't seem to have excessive anxiety, or it doesn't cause suicidal, ideation, for example. So that's been looked at. But what we will need to start testing ApoE status because of this drug, if this drug lecanemab is going to be paid for by Medicare, because we do know that if you carry ApoE4, you are at a slightly higher risk of these potentially serious side effects of fluid shifts and brain bleeds. And so Medicare doesn't pay for ApoE4 testing yet, but this will need to be a part of determining, you know, the safety of someone starting this monoclonal antibody treatment. But it's I think it's still an open area to figure out how this will be used clinically otherwise.
Well, thank you for making some extra time, and
Sure.
we look forward to staying in touch, and thank you again.
Okay, thank you. Bye.
Bye.